Well, hello, everyone. This is Dr. Amigues, your host of the UnabridgedMD podcast. And today, I am so excited to do the beginning of a two-episode series with Dr. Lauren Zimski. We're going to talk about dry eyes. We're going to talk about treatment of dry eyes. And we're going to talk about what causes dry eyes when it comes to a rheumatologic disorder. Dr. Lauren Zimski is an ophthalmologist that is specialized in dry eyes. You're going to hear from her. I'm gonna ask her a ton of questions. You're going to see. And we're going to be so lucky to learn more altogether about this issue that's affecting so many people, and especially in Colorado because it's so dry. Dr. Zimski, thank you so much for being on the show.
Thank you for having me.
Yeah, thank you. Can you tell us a little bit how you got into ophthalmology and into the world of dry eyes?
So I have been in private practice here in Denver since 2007. And dry eye has always been a big issue here in Colorado. And for a long time, we just didn't really have a lot of great treatments for it. Often we would just tell people to use artificial tears. Sometimes we would prescribe anti-inflammatory drops, but it was really limited. And unfortunately, it's a really common problem, and a lot of ophthalmologists and optometrists don't have a particular interest in it. And over the years, I just started seeing more and more patients with really severe dry eye. And it's something that typically gets worse as we get older, especially in women. So I had a lot of patients in their 50s and 60s coming in with dry eye symptoms, and we would try and treat it, sometimes with success, sometimes not. But over the years in practice, I've just been seeing more and more younger people coming in with really severe dry eye. And it just started to concern me because we know that it gets worse as you get older. So when I'm seeing these 25 and 30-year-olds with really just dried out, desiccated surfaces that are really suffering and are, really symptomatic from it, I just kind of started to wonder what's going to happen to these folks as they get older and when they get into their 50s and 60s, and what can we do now to stop the progression of this disease?
Oh, that's so great. And yeah, I mean, I think I saw you as you were going into this part, and I have to say that as a rheumatologist, I'm so grateful that you're offering those services because there is particularly one autoimmune disorder, and we will talk about this more in the second part of this podcast series. But really, like Sjogren, like dry eye, dry mouth, dry many things, really glands, can cause so much issues. And what I have found is that it's very rare that ophthalmologists offer more than just, some sort of, tears and then artificial tears and maybe like Lacrimal plug. So let's dive into from an ophthalmology standpoint. I'm sure you hear a lot of people saying, I have dry eyes. What is actually dry eyes when it comes to ophthalmology? Like, what would you consider is dry eyes?
So, dryness, it can really be signs or symptoms, and those things are often incongruous. So sometimes we have patients and they're coming in, typically complaining of burning, dryness, fluctuating vision, those sort of symptoms. A lot of times it's redness. Sometimes people just don't like the appearance of how their eyes look, even if they don't feel particularly terrible. And then there can be patients that come in with really no symptoms, and then you look at their eyes and their cornea and the surface of their eye look terrible. So there can be this really huge disconnect between the signs that we see on exam and the symptoms that people are feeling. So it can be a challenge to kind of get through all of that.
Okay, yeah, that's super helpful. And then when you see a patient that's complaining of dry eyes, what's kind of like your thought process as an ophthalmologist? What are you thinking as an ophthalmologist, and what are the kind of questions that you're asking your patients to go to the next step, basically?
Yeah, so that's a great question. So dry eye is actually a complex medical condition, and a lot of times it can be challenging to kind of get to the root cause and figure out what the most effective treatment is going to be. So I've really, since I've got more invested in this space, I have a questionnaire. So anybody that comes in to see me for a dry eye evaluation, it's a separate evaluation from any other part of the eye exam just because it's quite involved. And so I designed a form that everybody gets. And so the form really goes through their entire, their health history, what treatments that they've tried before for dry eye, whether or not they have potentially signs of autoimmune diseases like joint pain, rashes, those kind of things, just because there is a high incidence of dry eye with autoimmune diseases. And then I do a questionnaire, and I try and do the questionnaire every time someone comes in. And it's really just a way to quantify their symptoms and how bothersome they are. So essentially you get a score, and it's really helpful because a lot of times people have had these issues for such a long time, and it's such a chronic problem. And things can often get better slowly, and sometimes people don't always appreciate that. So by comparing their scores over time, it can be really helpful. And I think the other part of dry eye is it really goes hand in hand with a lot of skin conditions, which people don't always think about, which is sort of outside the realm of ophthalmology. Particularly if patients have had acne, a lot of times they've been treated with Accutane, which impacts the sebaceous glands, but the glands in our eyelids are sebaceous glands. And so there's a lot of thought that it's only a short-term problem while you're on the medication, but in reality, we see a lot of long-term problems after use of Accutane. And the other big driver that is very common is rosacea, which is an inflammatory condition of the skin, and people often think about it on the nose and the cheeks, but it actually affects the eyelids and the oil glands in the eyelids. And so there's a lot of connection between all of these things.
That's really cool. And so when you see this, and I'm really understanding more why in like insurance-based practice, you don't have the time to do this.
It is very time consuming.
Yeah.
And that is, I think, the reason that more people are not interested in it.
And it's so important for, but so once, if you were to see this, and if you were to see that there is like, maybe it's related to the Accutane from like for the acne, or that it's related to rosacea, do you refer back the patients to dermatology and ask them to help with that? Like, how does that help, basically knowing this?
I mean, typically I don't. The rosacea part is pretty common in the eye world. And so I've gotten more comfortable just incorporating some of those treatments into my practice. And, you know, the eye part is sort of separate from that. So the dermatologist, while they might treat the rosacea on their cheeks, it's not really going to necessarily improve their oil glands and their eyelids. There's definitely some overlap. Like the dermatologists use a lot of doxycycline to treat rosacea, and that definitely helps. That can help with the ocular rosacea too, but that's something that I often prescribe on my own. So I do, if somebody has really severe facial rosacea, you know, I will suggest that they see their dermatologist, but the majority of the time, you know, the dermatologist isn't going to really do anything that's going to improve their eye issues.
Okay, well, that's really interesting. So, okay, so let's say you have someone. So now we've said, okay, someone has dry eyes, or maybe they've been referred because maybe the rheumatologist think, okay, maybe there is dry eyes. They see you, they fill this questionnaire, and you make sure that they don't have a cause for the dry eyes, and then you treat the cause, and then they are left with, I have dry eyes, maybe I have corneal abrasion, as you mentioned. How do we treat this? Because, I mean, really, in medical school, the only thing we learned was artificial tears, maybe lacrimal plug. And I want you to talk about what's the goal of the lacrimal plug. And just, you know, that's all. Like, that's literally all we have. That's all we were taught we had.
Right. And there's been a lot of advancements over the past couple of years. So we have a lot of new tools that we didn't have, at least back when I was in medical school and residency and training. But basically when somebody comes to see me, so I'm fortunate, I have an imaging system, and that imaging system provides a lot of information, and also it allows me to show the patients what I'm seeing, which I think is really helpful to educate people, particularly because this is a chronic disease. We can treat the symptoms, we can make it better, but it never fully goes away. And I think to get people to really buy into treatment regimens and long-term plans, it's really helpful to have a picture and show them this is what's wrong. And then I also think it's really helpful to show them over time the improvement that we're seeing, because a lot of times it's a big commitment on their part to get things better. So the first thing I do as ophthalmologists in our training, typically the first thing that we do is just talk to the patient for maybe 2 minutes, and then we slide our slit lamp in front of them and we take a look at their eyes, which doesn't work in dry eye because you really do first need a good history, which I do get through our intake forms. But then I actually look at their face. So I'm looking to see if they have signs of rosacea. And I'm looking at their eyelids. Are their eyelids in a normal position? Do they look to be blinking normally? So there's a lot that goes into it. There's an association between sleep apnea and having floppy eyelids. And so basically what that means, oftentimes in the middle of the night, their eyelids aren't closing all the way. And if you have eyelids that aren't closing all the way or fully sealing even when you're sleeping, there's no treatment that's really going to be effective until you get that under control. So you've got to kind of take the big picture into account. So that first just starts by looking at somebody's face and, particularly their eyelids. And then I will bring the slit lamp over, and I will basically I will take a look at their eyelids. Like when you have ocular rosacea, you get these big inflamed blood vessels on the eyelid, and it often gives the appearance of red eyelids. But when you're looking under essentially a microscope, you can see these huge tortuous telangiectatic vessels. And then you just know when you see those big blood vessels that they're oil glands. They're going to impact the oil glands. And so those are sort of the first things I look at. The other thing is Demodex, which is a mite that lives on our skin, tends to over-proliferate in certain skin conditions like rosacea, and it really affects the meibomian glands and causes a lot of redness and inflammation. And we've never had, the dermatologists have always had ivermectin cream and various treatments for it, but we've never had anything safe to go in the eye to treat it until the end of this past summer. There was a drug that came out, an eye drop, a 6-week course of Xdemvy. And so often that is a major trigger for inflammation of the eyes. So we have all these things in our toolbox now that we didn't really have before. And so that's kind of how I start. And then I will put some dye on the surface of the eye, fluorescein dye. And I have a special filter. And so I can look at any staining of the surface of the eye on the cornea, the conjunctiva, and I can look at the tear breakup time, which essentially your tears should not start to evaporate for at least 10 seconds. So if they start to evaporate more quickly, it means that the oil glands, the meibomian glands, are not likely working like they're supposed to. And then I actually have an infrared system that allows me to image the meibomian glands. So I look to see if the structure of the meibomian glands is normal. So basically, in advanced disease, they get shortened or they completely drop out. And if you have absolutely no oil glands, that changes our management because we can't necessarily get those oil glands to work better. And then once I see what your oil glands look like, I actually push on them to see what kind of oil is coming out. Because ideally, every time you blink, you should squeeze out a little bit of oil, and it should ideally look like olive oil, and it should coat the surface of your eye and keep your tears from evaporating. But sometimes it looks like toothpaste, and that doesn't help the ocular surface.
Well, that's really interesting. And so that's more like for the diagnostic and like figuring out what does the patient needs. I know that like I'm sure it's depending on each patient, but I just wonder if you had to give an overview to someone with dry eyes or to me as a rheumatologist, what's the step? Is there like a stepwise process, or is there more of a, okay, you have this, so I'm going to treat you like this. You have that, so I'm going to treat you like that, and so on. I just wonder.
So there is a stepwise process, but it really depends on the diagnostic tests. So one of the tests that I think that we always do on new dry eye evaluations is called Inflammadry. So it's basically a point of care test where you just blot the tip of this applicator on the surface of the eyelid to collect tear film, and then you let it sit for 15 minutes or so, and it's either positive or negative for inflammation. So it looks for MMP9, which is an inflammatory marker. And so there's a lot of the literature says that, dry eye is driven by inflammation, and a lot of it is, but not always. So the first thing is, if this inflammatory test is really, really positive, and there's a lot of inflammation, the first step is always to kind of get that inflammation under control. And you never want to put punctal plugs in somebody that is really inflamed, because the punctal plugs will make that worse. And so while I do use punctal plugs, I use them, pretty judiciously, and I tend not to use them in inflammation.
Can you explain what punctal plugs are?
So punctal plugs, so we have a tear drainage system. So there's little openings on the lower lid and the upper lid. And basically our tears, as long as our eyelids are in a normal position, they will drain through these little punctum, and there's a little sac underneath the corner here. And then they drain down into our nose in an ideal situation. And so you can both increase the natural tears on the surface of the eye, plus any artificial tears or medications you put in the eye, by putting a little plug into that opening. And we always sort of used to use these permanent silicone punctal plugs that would basically stay there indefinitely until you kind of rub them out. Eventually, they would fall out. But now we've gotten more into using dissolvable plugs, and they last for different amount of time, but typically 3 to 6 months, just because something that sits, this foreign body that sits there indefinitely, can collect makeup and bacteria and various things that we're thinking, well, maybe that's not so great for the ocular surface over the long term.
That's kind of cool, yeah. So tears, then you would put the plugs, and then what other? Because you told me, and you were very excited about the LPG. You're gonna have to
IPL.
IPL. Okay, I wasn't too far. No, I was very far actually. The IPL, because that's it was really, for everyone that's listening here, it was super exciting to hear you talk about this new technique to help patients with dry eyes. And I remember we were at a coffee shop talking about this, and there is this lady next to us who was like, wait, talk to me about this. I need this.
She's actually my patient.
Of course she is. Of course she is. I love it.
So IPL, it stands for intense pulse light therapy, and it's basically been used for a really long time by dermatologists on the face. And it's really helpful, especially for redness and inflammation. So the light, there's different filters that we use, and it is taken up by blood vessels. So it really targets inflammation on the skin. And we have learned over the years that basically it's really useful for rosacea. It's definitely one of the more effective treatments, and dermatologists have used it for years on people's cheeks and their noses to treat rosacea. But then it was observed that their dry eye symptoms were actually improving by just applying this basically filtered light to the face. And so now there are devices that are FDA approved to actually treat dry eye. And the hand piece, it's the same technology essentially that what's used to treat facial rosacea. and age spots and various things on the face, but there's tips that are designed to basically contour the eyelids. So we can basically apply this light directly onto the eyelids after we protect the eyes with corneal shields to make sure that the light is not getting absorbed by the eyes, but it really gets taken up by these big inflamed blood vessels, and it helps the oil glands, my meibomian glands, to actually function better. And so it really treats the root cause of these issues. I have to say, of anything that I've done, it is one of the there's never one treatment that fixes everybody. But of all the treatments, I think that IPL has just been the most effective for the most people. So it's been a lot of fun kind of learning more about it and incorporating it into my practice.
I just want to make sure. So do you think that every person that or that the vast majority of people who have dry eyes would actually benefit from that? Is that what you're saying?
Not everybody. So part of it is kind of dependent on the cause. So if you have a positive inflammadry and your oil glands are either not producing enough oil, or your oil glands are producing really turbid, thick oil, it really improves the quality of that oil. But to be honest with you, I don't actually lead with it. It's not a first-line treatment in my practice because it is not something that's covered by insurance. It requires multiple sessions. And I think really to get the most benefit from it, you need to be on a good home care regimen, which for oil glands typically involves fish oil, ideally in a triglyceride format because that is absorbed better. And then just
oral.
What'd you say?
Is it a pill or is it just
it's a pill? Yeah. So fish oil, there's been controversy and studies, some showing it's beneficial, some showing it's not beneficial. But the reality is a lot of fish oil out there is not well absorbed. And so I think the data for fish oil is definitely supports its use. So I recommend fish oil for anybody that has meibomian gland dysfunction. And then basically cleaning your eyelids, because we have all these oil glands, we have eyelashes, we have hair follicles. And if you think about it, we wash our hair, we wash our faces, but we really never think about our eyelid margins until you have a problem. But when bacteria and oil basically overproliferates, it causes a lot of inflammation on the lid margin. So really sometimes just starting fish oil, cleaning your eyelids. I like a dilute hypochlorous acid that's designed for the eyes. And then doing warm compresses, because those warm compresses really help to loosen the oil and get it flowing again. And so I think that having a really good regimen, basically some people, first of all, that's enough. And second of all, is even if you do wind up going on to have IPL done, it really prolongs the effects of it because your oil quality is just better.
Yeah. I'm just going to pause this because I really hope there are rheumatologists out there that are listening somehow to this. I really hope so. Because, really, the only thing we know is, and I'm not even sure everyone knows that, but I guess most, is artificial tears and then sending the patients to an ophthalmologist to put plugs. And that's all. And then you're like, okay, bye. And the problem is that because ophthalmologists, the vast majority of time, don't do much more than that, we kind of look at our patients and are like, I'm sorry, So I'm lucky that I can send my patients to you, which is and they're lucky. They are really lucky because then it's not just that. It's so much more that you can offer. And while I think the plugs do work, I've definitely seen incredible improvement after that for my patients. I do think some of them need more than that. And I've seen the outcome that
it really depends on the severity.
Mm-hmm.
I have some patients. I have a young guy, he's like late 20s, early 30s with Crohn's disease. His ocular surface is, oh my God, he is just suffering. He can barely keep his eyes open because his ocular surface is in such bad shape. So it really depends on the severity of it.
But it's cool
to we have so many new medications. Exactly. That's the other thing.
Yeah, exactly. Is there anything else you would want someone that has dry eyes to know? I think right now, from what we gather, you're basically saying, hey, look, you need a good intake so that it's not just an eye exam, but it's really just a full exam. You need to make sure of what you have, because you may have a dermatologic condition, a rheumatologic condition, and so on. I'm sure you go over the medication and all this. Then you need to have a good regimen of making sure that you're washing your eyelids, you're putting compresses to extract a little bit the oil. And then you're saying, well, there are some artificial teeth for sure. There is some plugs that we can put, but there are other treatments as well. Is there anything else that you think we should know when it comes to dry eyes?
I mean, there's so much, so I don't know like how much. But I think the biggest take home message is, unfortunately, and I don't know the best way to like say this, most ophthalmologists are not really interested in it and don't have the time or the equipment to like really address it. So you really have to go to somebody that has this interest, because artificial tears and punctal plugs they're not the answer anymore.
Yeah, no, that's right.
They were the answer, but if you have massive inflammation on the surface of your eye, like you have to get that under control.
Yeah, this is super important. Well, so I think that this will be a really nice way to finish this episode, because I would like you to do two things. Number one, tell us a story of hope, because this is hope driven by science. So there has to be, I'm sure, because I know some of your patients, because we share them. So yes. I know some of the patients have incredible outcomes. So I'm not asking you a hard question. It's a very easy question. So someone that came to you and, like how maybe what, thanks to your care, they did much better. And then if you can share where someone who would need you can see you.
A lot of patients that come to see me have already seen a bunch of eye doctors in the past, and they have not been, they haven't been helped. And it's a huge quality of life issue. A lot of patients are coming to see me and they're sort of desperate for help, and they're frustrated because they've seen a lot of doctors and they haven't been helped. And so I would say, part of it is they're grateful just to have somebody that actually listens to them and is really focused on these symptoms, because oftentimes they've kind of been brushed off in the past. And I really do enjoy doing this. And so I think part of it is that just comes across, particularly after they've been seen by people that aren't really interested in helping them get better. And the dry eye, the condition, there's multiple different causes of it. It's a challenging condition to treat. And so I really try and do enough diagnostics tests to give me the best chance of coming up with a treatment regimen that's going to work. And even when I do that, there is trial and error involved. That's just part, and I think that probably goes for the whole rheumatology thing too. I'm sure that there's some you can come up with what you think is going to work, but then over time you have to modify things kind of depending on people's treatment responses. But I think over the course of time, I've had so many patients that have been so miserable and frustrated for a long period of time, make huge improvements. It's just really rewarding.
That's very cool. Okay, and so if someone that's listening to the podcast or looking at the YouTube replay wants to see you, where can they find you? Where is your practice? How do they get in touch with you?
So my practice is near downtown Denver. It's basically in a medical office building attached to the Presbyterian St. Luke's Medical Complex. And I have a website, laurenzimskimd.com. And you can certainly send me a message through my website. And I also have quite a bit of useful information on there. So I'd be happy to hear from you.
Wonderful. And Lauren, also, just so that you know, Lauren Zimski is on Instagram.
I am on Instagram and Facebook too.
We're trying to get her to put more stuff out there. But what you put is amazing. And, I do have this love-hate relationship with social media. So I'm trying to love it.
I'm trying to love it more.
I don't know. It's not easy. For sure, it's not easy. But we're trying to put you out there more, because what you have to share is just so valuable. All right. Well, Lauren, thank you so much for coming to the first part of this series of 2. I'm so excited to have you again. And so the next step, like everyone, come back next week because Lauren is going to basically interview me when it comes to when you have dry eyes, when should we think of if this is a rheumatologic disorder and so on, and so on. And we will talk about Sjogren, and I think that will be super valuable. Until then, both Lauren and I accept new patients. So please come and check out our website and then share this episode with someone that you think would benefit from it. I'm going to share this episode with all of the patients that I have who have dry eye, and there's a lot of them. So thank you again, Lauren. Have a great day.
Thank you so much. It was fun.